Friends, today I will be continuing my lecture on heart failure. Today's topic I cover the progression and pathophysiology of heart failure. Yesterday I defined the heart failure. I gave the magnitude of the problem, how serious the heart failure is. Think that the persons above 65, 10%, and that is 1 in 10, and persons above 85, every alternate person, and the persons with 85 or above, the mortality is very high. So that means it's a very serious and severe problem for all of us with increasing age. Then I also gave you the idea about the causes of the heart failure, taking an analogy with the water pump, and then describing the various factors that can produce the failure of the heart, that is the energy deficiency, or the defect in the contractile machinery, or the defect in the tubes and valves, or maybe external factors like restriction by the pericardium, or the greater hyperdynamic circulation. I presented the clinical manifestations of the heart failure, and I try to give the physiological reasons for that, and I provided the classification of heart failure according to the manifestations in the sense whether it is acute or chronic, right heart failure or left heart failure, systolic failure or diastolic failure, or something like that according to the manifestation. So then I also gave the classification or different classes of the for the New York Heart Association. That means class 1, class 2, class 3, class 4, mild, moderate, and severe. That means no no defect, mild, moderate, severe. So like that, I gave all that. In this lecture, I continue with the same thing. What are the various sequence of events happen after the heart failure? That's one thing I would discuss. I would discuss the hemodynamic changes happening after heart failure in the forward direction, in the backward direction. And I will try to provide different phases in the progression of the heart failure, how the heart failure progresses if in a given situation with without it, mostly think that it is not well treated. Then I will provide the various global physiological changes happening in heart failure. Now, just revise the definition of the heart failure. It is an inability of the heart to pump sufficient oxygenated blood to the metabolizing tissues despite adequate filling pressure, or just simply failure of the heart to pump enough blood to satisfy the needs of the body. Considering the point that it's not a single disease, rather it is a syndrome of multiple diseases or multiple system involvement, and often heart failure is the final and the most severe manifestation of any type of cardiac disease. Hence, understanding the pathophysiology and the progression of the disease will be of great help in planning the management of the disease. So that is the crux of the heart failure. Now, let us consider what are the various sequence of events happening after heart failure. One, there will be changes in the blood flow. That means hemodynamic changes, the blood flow parameters. So in the forward direction and in the backward direction. And these things I would take up in the coming slides in detail. Then there would be activation of the Starling's law because of the stretch, because of the increased right atrial pressure or increased filling. The Starling's law comes into action because the Starling's law states that within the physiological limits, it is the function of the length of the cardiac muscle. So it's within the limit because during this period there will be an increase in the force of contraction or the ionotropism which the cardiac muscle manifests. So that would happen in the initial stage. Then it would activate the sympathetic system that I would cover, and there will be activation of the renin angiotensin aldosterone system because of the renal perfusion is diminished, and then repair and remodeling. Now, let us go to the hemodynamic changes in the forward direction. Consider the left heart fails. When the left heart fails, the ejection fraction decreases. The decreased ejection fraction or stroke volume decreases the cardiac output. The decreased cardiac output decreases the carotid sinus firing. So that means it decreases the blood pressure, and the decrease in blood pressure decreases the carotid sinus activity. That means it decreases the barrel discharge. If the fall in pressure is too severe, then it may activate or increase the chemoreceptor discharge. Or if it is even a little higher, decreases a little more, so then it would activate a brain ischemic response. Whatever it is, primarily it is the decreased barrel discharge, so that through the NTS will enhance the sympathetic discharge. That means a decreased carotid sinus firing will enhance this thing. It is a sort of a withdrawal of the effect withdrawal of the effect. That means these glossopharyngeal and vagal inputs reaching the NTS, they would be inhibitory, and this inhibitory is diminished and increased sympathetic discharge. Now, what the sympathetic discharge does, it will increase the force of ventricular contraction, left ventricular contraction. So that would increase the cardiac output. That will try to increase the cardiac output. It will increase the rate at which the heart beats. That means the cardiac rate or the heart rate increases. That would further increase the cardiac output. So if you are looking at the cardiac output, it is the product of the stroke volume and the rate. And the sympathetic sympathetic nerves supply these peripheral vessels, and there is a venular contraction, and that would increase the venous return. The increase in the venous return increases the preload. Preload. That is one thing. That means the increased volume entering into the right atrium and subsequent. Okay, that may try to compensate for the cardiac output. And because of the arteriolar contractions, constriction, that increases the afterload. These are all the sympathetic discharge does, so that would try to compensate for the decreased cardiac output. Now, the question is here whether this decreased, whatever the cardiac condition that has resulted in a cardiac output, will be able to accept that we have to deal. Another interesting thing you can see here, the sympathetic activity that would activate the renin release from the kidney. So that is the another this thing. That means there are five factors I am trying to show you how this would activate try to improve the cardiac output. Now, when this is happening within a few minutes of the change in the cardiac output. Now, so in the long-term regulation of blood pressure, because this may, if it is not able to cope with, so then the other long-term regulators, they try to play around. These in the long-term regulation, we have these, there is a diminished renal blood flow, and because of the decreased cardiac output. And this diminished renal blood flow increases the renin release from the juxtaglomerular apparatus. And this renin activates the angiotensinogen circulating in the plasma and converts into angiotensin 1. Now this angiotensin 1 is converted to angiotensin 2 in the pulmonary, in the lungs, and in the liver, where in the lungs the angiotensin converting enzyme is expressed at the maximum. So that angiotensin 2 is expressed. Angiotensin 2 is a powerful vasoconstrictor. By the vasoconstriction, it will increase the afterload. Point number one. So that means it try to increase the blood pressure. The second, it will also do the venular contraction. The smooth muscles of the vein or venous system is also that would try to increase the preload. The increase of the preload increases the cardiac. So that means we have the angiotensin 2 is increasing the afterload and preload condition. That means the venous return and the blood pressure. Now, angiotensin 2 also expresses certain enzymes. So that would be remodeling the uh, heart structure as required. So these are the hemodynamic changes in the forward direction. Okay, if the condition by which the cardiac output has diminished because of the heart failure, if that is not addressed, because here it is only compensation is to see that cardiac output is regained, but whether it is whether the heart is capable to do it, that we have to see with the condition. Now going with the backward direction, hemodynamic changes in the backward direction. This is something like a putting a dam. That means it produces a damming effect. That means you have put an obstruction, and this obstruction, there is a back pressure building up, then back water accumulation. Let us see what happens if there is a failure of the left ventricle. And if this left ventricle fails, the stroke volume, that means it cannot throw out all the blood present in the left ventricle. Now the stroke volume decreases. It may be because of the aortic stenosis, or it may be because of the uh, any other condition which increases the diastolic volume. That means aortic regurgitation or stenosis. That means the volume of the blood in the left ventricle increases. Now the increased left ventricular volume increases the left ventricular pressure, and the increased left ventricular pressure does not allow the emptying of the uh, atrium. That means AV valve that is not able to empty all the blood, because it is the emptying of the the blood from the atrium into the ventricle, mostly because of the pressure gradient. The atrial contraction contribute only 10 to 15% of the total ventricular filling. It is mainly because of the pressure gradient. P atrium will be greater than the P ventricle, and then the blood flows from the atrium into the ventricle. Now, if the ventricular P ventricle is equal to or greater than this thing, so the blood remains in the, rather blood enters into the atrium, so that is not able to empty, and there may be a blood remaining in the atrium. The blood, if it remains in the atrium, that would be a back pressure on the pulmonary vein. the pulmonary veins are they are filled up, and that would have exerted pressure on the pulmonary vessels. There will be the pulmonary edema because the blood is not going for the rate. There is a stagnation, the pulmonary edema, and this pulmonary edema comes in the way of oxygenation, the perfusion, the ventilation and perfusion. The perfusion is diminished, and that would produce the hypoxemic state, and that may be a resultant of the dyspnea. Cyanosis, because it's not the blood is not oxygenated. There is no oxygenation because it's not moving at all, and because of this there will be activation of the uh, receptors, the lung receptors. They will produce the cough, maybe J receptors, other the receptors which produce the congestion. They will be activated. These are pulmonary C fibers in the vagus. They are activated. They produce the cough. So for this reason, person either will have a orthopnea because there will be he will be breathless if he lies down because all the water comes there. So now he has to get up so that some part of the lungs remain ventilated. Or what happens in case of mitral stenosis? There will be building up of these pulmonary edema over the time, and suddenly there is a paroxysmal nocturnal dyspnea. That means there is a dyspnea which happens in the night and it comes as an attack. So there will be a nocturnal dyspnea coming in attacks. So that means he is sleeping, he is comfortable, and then suddenly in the night, because the back pressure keeps on building, the oxygen lack take place. There is hypoxemia, and he wakes up because of the choking or the breathlessness, and then he tries to recover and then again goes back, and this cycle continues. So now, if the pressure in the pulmonary vein increases further, there would be a back pressure on the pulmonary arterial side, or pulmonary arteriolar capillaries, and the pulmonary arteries, and the right ventricle, and then right ventricular accumulation. That reflects back on the right atrial accumulation, and this right atrial accumulation builds up. So then the venous return diminishes, because venous return is because the right atrial pressure is nearly somewhere around zero or little lesser than zero, -1, so that the blood flows from the lower extremity into the right atrium. So now, if there is a pressure there, there is no venous return. The blood in the veins remain accumulated, getting stagnated, and that increases the venous pressure. So there is a pressure in the atrium, and that increases the venous pressure. And because of the venous pressure, what happens? Number of things happen. One, there is accumulation of the fluid in the peritoneal sac, the ascites, what is called a dependent edema. Then maybe when a person sleeps, there may be accumulation of fluid in the pleural cavity also. The ascites or a pleural effusion that may take place. Then we have a hepatomegaly, because the pulmonary vessels, or the portal vessels and the hepatic vessels may not be able to return. So the blood gets engorged in the liver, and that would produce hepatomegaly. And these are splenomegaly, because the mesenteric vessels are engorged, the spleen is getting enlarged, and you can see them as a pedal edema. Yesterday I have shown the picture where we have the edema of the foot. So these are the damning effects. Now we move further. What happens here? You just see the changes after heart failure. So now here is a condition. This red one is a normal heart. That means without any failure. And this condition. So now the right atrial pressure, as I mentioned, somewhere around -1, 0 to -1 millimeters of mercury. It's in the normal condition. At this condition, the if the stroke volume is around 70 ml, per stroke, and the cardiac output is around 5 liters. You can just see that around 5 liters there in the point A. So now the point, then there is a heart failure, because this is a sort of acute condition. In the acute heart failure, what happens from in this condition, the individual will suddenly, the heart stops beating. So because of any other cause, yesterday we said. So now this is in reference to the acute myocardial infarction. So now what happens? The heart is unable to contract because of the infarction. Now it suddenly comes back here. The cardiac output diminishes. So the decrease in the cardiac output enhances the right atrial pressure. So just see that it becomes plus 4 millimeters of mercury, and the cardiac output has diminished. Maybe it has come about one third of this, maybe 1.5 to 2 liters per minute, less than 2 liters per minute. Now, after some while, maybe this happens within 1 second. Within a second, when the heart stops, the blood, this would fall, and that would reach to this level. Then comes there is a recovery, and this is a recovery phase. So that means because of the certain the changes happening, they will increase. So this is a damaged heart. So that means acutely damaged heart, this condition, and a damaged heart with the sympathetic stimulation, because sympathetic nervous system is activated. It would enhance the cardiac output. However, the atrial pressure remains same. It will try to this may be because of the two factors. One, sympathetic stimulation. The second, Starling's phenomenon. The third thing, because of the stretch here. Third thing is after some hours. So this is a partially after some hours, or yeah, they after one day. So this will improve. This will try to improve because of the other changes happening. So now that the changes that is leading to the improvement in the cardiac output. So you see, just see that cardiac output is coming to nearly 5 liters per minute, maybe somewhere around 4.5 or something like that. But however, you have this the right atrial pressure is increasing in these conditions. So this is happens in the seconds, the minutes, and the hours. That is how it's happening. This is because of the decreased cardiac output and the damming, the venous pressure increases, damming effect. Now, what are the different phases of the heart failure? So that means if there is a heart failure, if I'm going back here, so this means we have A, B, C, D. So that means there is a sudden decrease, and improvement, compensation, and then there is some stability. Now, if you are going back, there are nearly 4 to 5 different phases happens in the cardiac failure. So the initial phase, where there is a sudden drop of the heart functioning stops, the cardiac output decreases. That's the initial phase, and that is compensated. This is a compensated phase. So this compensated phase, which progresses, because whether this compensated phase, if it is not the real problem that has caused the heart failure, if it is not addressed, so it progresses, it goes further, because it is not able to withstand whatever is happening, because the right atrial pressure is keep on increasing, and this progression brings about changes in the uh, heart muscular size, shape, and other things, that is called a remodeling, and that changes that brings about. So that means it progresses with a remodeling, and a stage will be reached, so it is no more able to hold, because the heart failure, the basic cause of the heart failure remains. It is no more able to hold the whatever the compensation, it gets decompensated, and if it is not attended, maybe he will die. Now, what is important here for the treatment aspect? Maybe the initial stage and the compensated stage, we have to take care why the heart has failed, and we have to address that. so that it will not enter into the progressive stage or in a remodeling stage. Once this enters into the progressive and a remodeling stage, so these are remodeling is an irreversible thing, and then that may be producing the greater mortality of the individuals. Okay, so thus I have a 4 phase listed here: initial phase, compensated phase, progressive phase with remodeling, and a decompensated phase. Let me take this initial or acute phase. This happens within second, and this is because of the decreased cardiac output. So this is decreased cardiac output. Now what happens? There is a damping effect. This damping effect increases the right atrial pressure. Now that sets the compensatory mechanisms to be activated. This is about the initial stage. Then this after second or after some 30 seconds or 40 seconds, the compensatory mechanisms begin to operate. So now this is a compensated stage. The compensation, what happens? How the compensation is taking place? In the compensated stage, there is a decreased blood pressure. There is a decreased cardiac output. Already you see that. And this decreases the blood pressure. The decrease in the blood pressure decreases the baroreceptor activity. So that means the number of discharges reaching the NTS via the glossopharyngeal nerve and the vagus nerve are diminished. And the NTS is not activated, which in turn have withdraw the inhibitory activity on the sympathetic nervous system that increases the sympathetic activity. Or if the fall of blood pressure is too low, that may activate the chemoreceptors. Chemoreceptors directly increases the sympathetic activity. Or if the fall of pressure is too low, further low, so that would activate the brain ischemic response, that will also activate the sympathetic activity. So that means decreased pressure leads to the sympathetic activation, the primarily because of the baroreceptor, decreased baroreceptor activity via the NTS, so that would enhance the sympathetic activity. I mentioned it's a withdrawal of the inhibition. Now, coming back here, what happens? The increase in sympathetic activity increases the heart rate. So that is what we have seen, the heart rate increase in case of the heart failure. That's one of the sign, and it is trying to increase the cardiac contractility, and it will try to increase the venous return that I have shown. So that means the venous return, and also trying to increase the pressure, that is afterload. So that means this is preload and the afterload. All these things together, they try to bring back the pressure. Okay, so now, so that is one of those sympathetic activity. What is happening here? This happens in minutes, maybe in 30 minutes. The person is coming back here to sea level. That means it is nearly 4 liters, nearly 4 liters per minute. Oh, that's okay. That's reasonably setting back. Now, what happens? Further, the Starling's law also brings into certain amount of force of contraction, because I mentioned the cardiac contractility is because of the sympathetic and the Starling, and these Starling and the sympathetic are complementary to each other. It is not only additive; it is a multiple, so that will enhance the force of contraction, that will try to bring back the cardiac contractility and the cardiac output somewhere here in the point C. Now, so now this would be okay, fine, it is happening, but whether it is able to sustain, that is another thing. Now at the same time, the renal blood flow diminishes. The decreased renal blood flow enhances the renin formation from the juxtaglomerular complex. The renin angiotensin aldosterone system is activated. Now we have two things there: angiotensin 2 is formed. Angiotensin 2 enhances the blood pressure. Angiotensin 2 enhances the smooth muscle contraction of the venular side, increases the preload, the venous return. Angiotensin 2 activates the aldosterone release from the adrenal cortex, which reabsorb sodium and water. so that more and more fluid coming in, and this is a stage D. It happens in days because aldosterone is a steroid hormone. It takes a little longer for the action. So this is the compensated stage. Think that in this compensated stage, the main cause of the heart failure still remains where it was. You are not going to catch or you are not going to treat that condition. In that case, what happens? So it progresses. Now, what happens? It is a situation in which the heart failure. So now this is where this is the normal venous return. So that means it has failed here. It has come back after the normal thing, and then B is the point where the sympathetic activation is coming back. That has come back to almost nearing to the stage of 4, maybe sympathetic and renal angiotensin aldosterone mechanism is operated. Then maybe after a second day, so this is second day, it is almost touching that 5 liter mark. So now it is the seed here, but if you are looking at the bottom here, in this bottom you have the atrial pressure is increasing. So the atrial pressure here is 2 something, 2 millimeters or 3 millimeters, and here the nearly 5 millimeters, and here the atrial pressure, that means there is a backlog, there is a damming, or there is a venous pressure engorgement that's happening there. But it is trying to improve the cardiac output. It's not enough because there is a pressure on the heart. Now this pressure on the heart, it will be able to withhold for some level, maybe fourth day it will be able to. So on fifth day or sixth day, you just see that it's not able to hold because the pressure is more. And if the pressure is more, again the Starling's law fails. The sympathetic is not able to contract. So the contractile machinery is not. So there is a remodeling of the structures. It is trying to diminish. This is the critical stage in which the heart is not able to cope or produce the output. So there is a decrement. So now on eighth day, see, look at that. The pressure is 16 millimeters, and the cardiac output diminished to almost, you can see, two-thirds. So that means 5 liters means it has become only 1.5 to 1.7 liters. So you can just see that. And this is the stage in which there is no recovery, and the person ultimately dies. So this is how the progression is taking place. Now, looking back, how this progressive phase of the heart failure happens, let us try to understand this phenomena. One, decreased cardiac output results in increased end diastolic pressure, left ventricular end diastolic pressure. The increased, because of the decreased output, the end diastolic volume remains and the endostolic pressure increases. So this would increase, that would activate or produce the left ventricular hypertrophy. And hypertrophy here is not because the hypertrophy is happening, but whether it is the contractile tissue which is being hypertrophying, or a matrix tissue which is being hypertrophied. So we don't know. So that means it produces the left ventricular dysfunction. Left ventricular dysfunction. Maybe even if we consider, because of the left ventricular endodiastolic pressure, maybe lot of fluid, it has crossed that length tension curve of uh, the myosin actin filaments, so that cross bridge and these things, and it may not be able to contract, produce effective contraction, so that will produce the left ventricular dysfunction. Now, the because of this left ventricular dysfunction, what is happening? I have already mentioned the back pressure on the left atrium, and then back on the pulmonary vein, pulmonary wedge pressure. That is indicative of the pulmonary hypertension, and their pulmonary wedge pressure increases. If the pulmonary wedge pressure increases, there is a formation of the pulmonary edema. So now the formation of the pulmonary edema produces hypoxemia and all those signs and symptoms of the heart failure. This is where this cardiac output. Now, hypoxemia, it keeps on increasing. The hypoxemic status keeps on increasing. The vital organs, they suffer with oxygenation, and that may further add on to the problem. That means it makes this thing to progress, because if there is a hypoxemia leads to the cardiac oxygenation. That means the coronaries supplying the heart are not effectively oxygenated. That suffers, and it goes on and on. So that is one thing. And if you are looking at the brain, that is also having the brain and anoxia, or looking at the other organs like maybe the liver or other metabolically active organs, they will also suffer. So whole thing is goes in the what is that more and more in the other side, the positive directions, and a lot of other metabolites, the H ions and the toxins and the metabolic end products, they will keep accumulating. It produces hypercapnia and so on, hypoxia, hypercapnia, and so that would further decrease the activity of the cardiac action. Now, another thing here, so this may be the maybe beginning stage. That is, I have already mentioned about a sympathetic nervous system activation by three mechanisms: decreased barodischarge, increased chemodischarge, and activation of the brain ischemic response. Then I have renal blood flow, blood perfusion is decreased, activation of the renin-angiotensin system, they will activate. So now what is happening? The sympathetic contracts, sympathetic enhancement, increased sympathetic enhancement produces a load on the heart, because it increases the contractility, it increases the venous return, it has the afterload effect, and the heart rate increases. So everything is against, it's going against this whatever the heart activity, because the condition persists. Now, the renin-angiotensin system, this will also produce the afterload and preload problems. Then, as I explained, and also adding to the problem is accumulation of sodium and water increases the plasma volume or the blood volume. Now, besides these things, there will be other, because of the H ions and the hypoxemia and hypercapnia responses, other circulating paracrine effects will bring in, because accumulation of various metabolites that would try to stagnate, or that will try to have a counter effects on the circulation. Now comes what happens, the because of the stretch, you see that atrial pressure, if I go back to this thing, see, atrial pressure is increasing. So that means the atrium is being stretched and stretched, and it is the pressure that activates the release of the atrial natriuretic peptide from the atrium. So that means atrial natriuretic peptide is coming, and this atrial natriuretic peptide try to eliminate the sodium and water from the um, kidney. Now, this side, you just see the renin-angiotensin 2 trying to increase the sodium and water reabsorption. Now this atrial natriuretic peptide and the brain natriuretic peptide, because of brain ischemia, they will try to eliminate the sodium and water. So now it's a total system is in confusion. The system becomes confounded with this problem. So that means it's a counter regulatory. So it's against the regulatory effects of this. So that means it triggers in, and that progresses it further. Now, so also because of these, uh, the norepinephrine, angiotensin 2, aldosterone, the pressure, hypoxemia, and all these things stimulate the remodeling of the heart. And remodeling means the heart structure either fibrosed or become stiff, or it becomes thin, and maybe it balloons out, and there may be aneurysm and rupture. So that is what's the, so that further progresses, because it becomes weak in the other sense. It is not able to contract. Now, this is the progressive phase, how the remodeling is taking place. I have taken this figure from Joseph and Punjana from the New England Journal of Medicine, and you can just see that this is the initial infarction is here somewhere here. So then after the infarction, hours 2 days. So that means it's within 1 or 2 days. What happens? This infarction continues because there is some. It continues there and it is not able to contract. So now you just see this the ventricular volume. The ventricular volume is decreased, and even if you are looking at this the valves, they are not able to close. So there is some amount of remodeling of this thing. This would because of this there will be some defects manifesting. So now there is the activation of other things coming up. Then it is after the modeling, after remodeling, what happened? You just see that this is what has happened here, and this is replaced by the some tissue there. This is replaced by this tissue, and this is the place where there is infection, and this infection has killed the myocytes. And once they have killed or apoptotic changes in the myocytes, you just see that they are only made up of a thin rim of wall. So the no contractile, because if you are thinking at the left ventricle is very thick, so that diminishes, and at the same time you can just see that these uh, the valves which are this thing papillary muscles and the valves, they will be not guarded and they become weak, and there will be again the incompetence of these valves, especially the aortic valve or the mitral valve, that will just try to increase the load on the heart. This is one. Then another ventricular remodeling I am taking in the diastolic and systolic failure. So this is a normal heart. So then it is a hypertrophied heart because of the diastolic heart failure. Diastolic heart failure is the it's not able to relax. That means it has become stiff. So there is no refilling. There is no refilling. This is what it has. That means the cavity is diminished. This is systolic heart failure. You just see that the entire thing is the distended, dilated, and you see this. This is one of the remodeling. So now, if I come back here, the progressive alteration in the ventricular size. That means I want to define remodeling here. It is the progressive alteration in the ventricular size, shape, the function, due to mechanical because of the pressure, or neurohumoral because of those sympathetic, that is norepinephrine or angiotensin 2, aldosterone, or other hormones, or genetically getting expressed with a new molecules that may produce the apoptosis. And because of the inflammatory response, because there is some injury there, the inflammatory response, and the inflammatory response is followed by the repair process. So all these things would produce a change in the cavity and the functioning of the heart, so that may be detrimental to the function of the heart itself. That is the remodeling. Now, so because of the resulting cardiac hypertrophy, because of the remodeling, there is a cardiac hypertrophy, loss of myocyte, the scar formation. The loss of myocyte is due to apoptosis, the scar formation, the fibrosis, the interstitial changes, thinning of the wall, and may produce a dilatation and aneurysm, and may rupture, and a decreased heart mass or increased heart mass, whatever. These things reduce the cardiac functioning and progresses the heart failure further, because they are not replaced by the contractile sarcomeres. Maybe some matrix proteins are expressed, and so those expressions are activated by the genetic factors. Sometimes it thins, the wall becomes so thin that that may even rupture and may cause death. So this is the remodeling phase. Now coming back here, how the entire thing, if you are looking at how the progression of the leads to the decompensated stage of the heart failure. Now you look at here. So we start from this point. Systolic heart failure, reduced cardiac output, the increased sympathetic activation. This increased sympathetic activation produces the vasoconstriction. The vasoconstriction increases the cardiac filling pressure. That means pressure there. So that means the venous return is increased, and it also try to uh, balance balance the reduced increase the cardiac output. Now this is one way. So now the second thing is what happening, reduced cardiac renal blood, reduced renal blood flow, activation of the renin angiotensin system. That means renin is activated, and angiotensin 1 is formed, and this sympathetic also activates renin. Angiotensin 1 is formed, angiotensin 1 to angiotensin 2. Now the angiotensin 2 produces the vasoconstriction that increases the cardiac filling, as well as trying to increase the cardiac output, balance the cardiac output. Now, at the same time, this angiotensin 2 activates the remodeling of the heart because of the pressure and other effects. And even angiotensin 2 itself is a molecule. Now, norepinephrine also will activate the remodeling or shape of this thing. Now, the angiotensin 2 activates the secretion of the aldosterone from the suprarenal gland or adrenal cortex, and aldosterone comes. This will activate the remodeling. Aldosterone tries to retain sodium and water, and this would further react to the filling pressure. You just see that the pressure is increasing for several fold. Minus 1 to 0 was the normal right atrial pressure, has become to 16 millimeter. That is a tremendous load. So now these all things would also produce the remodeling. Now what happens, this would produce the pulmonary edema, and this pulmonary edema interfere with the ventilation or perfusion. There is a total hypoxemic state, there is hypercapnia, and accumulation of the metabolites, and metabolic toxins are accumulated, because all the vital organs suffer with the oxygenation, and that would make all the molecules, and they will again depress the heart. So that means this will depress this, and that will, these brown lines are inhibitory, so that will diminish the heart failure, and that will go into decompensated stage. Now, the cardiac remodeling, because of the thinning, replacement of the the contractile sarcomeres from the fibrous tissue, so not functioning, so that will decrease the heart failure, and this would go on and on. So that would be the fate. Now I have mentioned here modeling, remodeling. I have already mentioned it's hypertrophy, apoptosis, oxidative stress, gene expression of the ion channels, and ischemia, and all those things happen. That is how this globally you can just see in this graph. All things are done. Now coming back here, I'm just taking the how the critical stages. You can just see from the type A is the initial stage, then B is a compensated stage, maybe in days. C is in days, trying to recover, hold on. So then E is the stage, maybe fifth day or sixth day, it tries to fall. So, but you just see this here, the right atrial pressure is enhanced or increasing, and finally the F is the stage where it's not able to hold on, it falls, and that would kill the animal. That will person will die. So depressed cardiac output indicates a decompensated heart, and progressive fluid accumulation reaches the right atrial pressure in days, in over a period of days, and the cardiac output progresses from A to F. You can just say it goes from here and it falls down and it comes to zero. Now, taking this, just I give you how if you have attended, if you attend this thing in the right moment, how it will improve. This is one of those the graph. You can just see that this is the severely falling heart. So this one, okay, this is the first day. It is here. The pressure is here, and this is E. Okay. So now, if it is not dealt with, the person will die. Person will not be able to recover. He will die. Now, what happens? This person has been, or these patients have been given digitalis. So now, the digitalis, that means, and they have started with the here in this H. They started the digitalis, and once they started the digitalis, so that has come back here. So you just say that this was E here, and that is the first day, and after digitalis, after administration, that is the cardiotonic drug, which is working with the sodium potassium ATPase. So this has come back, and the even the right atrial pressure is also diminished, and you can just see that. This will come back here maybe on first day after digitalis. Okay, so then after several days with the digitalis treatment, you can just see that the right atrial pressure is diminishing, and the cardiac output is returning to normal. So that means it has been trying to, the person is able to survive. So that means how effectively the perfusion and other activities are happening, and it will not allow the remodeling to happen, and that will produce the permanent damage to the these things. That is why the timely treatment is an important issue in the heart failure, and treat the cause. If I were to go further, the treatment and management, if you are looking at the it is the stage and the category or the phase in which the heart is, and even the cause of the heart failure has to be addressed. If you do with if you time it well, as I have shown in the previous graphs, so then he may have the chance to recover, prevent that remodeling, prevent those hemodynamic alterations, and give him the proper the conditions. Now, what are those treatment strategies? One, the alteration in the lifestyle management, that I would discuss in my next lecture, and provide bed rest in the severe cases, because he cannot be able to do any exertion. Any activity will make him breathless. In the stage 4 or class 4 of the New York Heart Association, he's dyspnea even at rest. So that means you give him the bed rest. Maybe he is definitely orthopnic, so he has to sit, and you give him some recumbent posture and elevate the foot end if a person is having that edema, so that you try to help the edema draining out, and you advise the restricted salt diet, so that you reduce the sodium, and sodium is associated with the water. You try to reduce the ECF volume, the extracellular fluid volume. These are non these are only by the changes in the lifestyle and other things. So non-pharmacological. Now, what are the pharmacological things you are trying to adopt? One, the diuretics. Diuretics, they eliminate the sodium and water, so that the load on the heart diminishes. It brings back the right atrial pressure to this thing, so that there is no remodeling takes place. Then use ACE inhibitors and angiotensin 2 receptor blockers, ACE inhibitors or angiotensin 2 blockers, either of them, because they have the similar thing. This blocks the receptor, this blocks the synthesis of the formation of the angiotensin 2. So now that would try to diminish the preload and afterload and the remodeling, so that may be useful. Then you use the beta blockers, because these are sympathetics, and these beta blockers would provide decrease on 4 or 5 counts. So how those 4 or 5 counts, I want to just say, because it decreases the force of contraction, it decreases the rate of contraction or rate of the heart, and increases the venous return by contracting the venular smooth muscles or the venous smooth muscles, and increases the or decreases the afterload. So that means it can pump out and activates the angiotensin 2 formation, renin things. So then you can use the cardiotonics. These are the strategies in the management of the heart failure, and these strategies would be uh, helpful to the patients. He can survive. So but if you are taking him in the last phase or in a progressive phase, so then it is difficult to prevent the remodeling and bring back the normal thing. Now, so these are some of the keywords uh, you can just try to think about and make your own notes. The ascites in heart failure, hepatomegaly in heart failure, stages of heart failure, the classification of heart failure, the forward effects on the heart failure, damming effect, the phases of heart failure, the compensatory phase, the progressive phase, decompensated phase, the cardiac remodeling. These are some of the keywords you may like to ponder about, and you may like to think about and make your own notings. Now, I have referred the guidance textbook. Those graphs, the atrial pressure and the cardiac output are taken from the guidance textbook, and some part I have taken from the Genong. And these two articles were of great help to me. The Jackson et al. From the British Medical Journal, and Jessup and Brojina from the New England Journal of Medicine. They are of great help to me. Thank you.